Imagine you are in theater. You've made your incision, you've carefully divided the transverse carpal ligament, and you're feeling quite satisfied with a very routine release.
Which is usually right before the nightmare starts, honestly.
Exactly, because as you clear the field, you realize the catastrophic error. You have just severed a transligamentous recurrent motor branch.
Yeah. And your patient is going to wake up with profound the ulnar atrophy and, well, a devastating permanent loss of thumb opposition.
It is the ultimate surgical nightmare. I mean, carpal tunnel syndrome is the single most common compressive neuropathy treated globally. It's the absolute bread and butter of orthopedic and hand clinics.
It is.
Yet, sitting here in 2026, the clinical paradox is glaring, isn't it?
Mm-hmm.
Diagnostic delays are rampant, conflicting management pathways persist across different trusts, and the rate of failed surgical releases remains remarkably, unacceptably high.
Well, the margin for clinical error in this supposedly routine condition is incredibly vast. We are dealing with a pathology that's been surgically treated for, well over a century.
Right.
But because we've industrialized the treatment pathway, we've somehow lost the vital nuance of the underlying cellular pathology. The assessment, the interpretation of the neurophysiology, and the actual operative execution, they require a level of precision that is often just glossed over in standard training.
Which is exactly why we're dedicating this time today.
Right.
So whether you are an orthopedic trainee navigating your first independent clinics, a hand surgeon refining your operative lists, a GP acting as the critical gatekeeper, or even a physiotherapist rehabilitating these wrists post-operatively, this deep dive is tailored specifically for you.
Absolutely.
Our mission today is to cut through the institutional noise. We are going to clarify the modern diagnostic criteria, aggressively debunk the clinical myths that stubbornly persist on the wards, and critically analyze the rigorous evidence for surgical versus non-surgical management in 2026.
To elevate our collective clinical approach, we must move completely beyond the basic textbook definitions. We have to examine the functional realities of the median nerve, its compromised microenvironment, and the actual mechanical forces acting upon it.
To accomplish that, we have structured a very specific narrative blueprint. We'll move from the sheer anatomical complexities of the wrist and the notorious CTS-NCS discordance problem straight into the biomechanical utility of conservative bridging strategies.
Brilliant.
From there, we will wade directly into the surgical evidence wars critiquing open versus endoscopic techniques, and finally unpack the anatomical realities of why surgeries fail and how systemic conditions in special populations demand highly tailored care.
It's a massive topic, but a crucial one.
It is. So to understand why a treatment fails, you must first establish how the condition is anatomically defined. Take us into the architecture of the carpal tunnel.
Right. Well, the carpal tunnel is fundamentally an unforgiving fibro-osseous space. You have the rigid carpal bones forming the floor and the medial and lateral walls.
Specifically the scaphoid, tubercle, and trapezium laterally, right?
Exactly. And the pisiform and the hook of the hamate medially. Bridging this trough is the robust, unyielding transverse carpal ligament, which forms the roof. Within this highly confined space, you have 9 flexor tendons.
Yeah.
That's 4 tendons of the flexor digitorum superficialis, 4 of the profundus, and the single flexor pollicis longus.
Okay, so 9 tendons.
9 tendons. And running alongside those 9 tendons is exactly one highly sensitive, profoundly vulnerable structure, the median nerve.
9 tendons, 1 nerve, and absolutely zero room for volumetric expansion.
0. The pathology is driven entirely by a mismatch between the rigid volume of the container and the expanding volume of its contents, usually due to tenosynovial proliferation.
Right, it's swelling.
Yeah. But the anatomical nuance that separates a safe, successful operative release from the iatrogenic disaster you described in the introduction that lies heavily in the variations of the recurrent motor branch.
This is the branch that innervates the critical thenar muscles, right? The opponens pollicis, the abductor pollicis brevis, and the superficial head of the flexor pollicis brevis.
Spot on. Now, in the classic anatomical textbook, this motor branch arises just distal to the distal edge of the transverse carpal ligament and sort of hooks back around it. We refer to this as the extraligamentous course, and it's present in roughly 50 to 80% of patients.
But textbooks rarely reflect the reality of a complex Tuesday morning operating list. I mean, we cannot operate on the assumption that the patient falls into that 80%.
We absolutely cannot. And this is where a thorough understanding of the Land's classification of median nerve variations becomes mandatory.
Okay, let's break that down.
Aside from the standard extraligamentous course, you have the subligamentous variation, where the motor branch arises underneath the transverse carpal ligament and runs dangerously close to the cutting surface before emerging.
Which is terrifying enough.
It is. And then you have the transligamentous variation. This is the true anatomical trap for an unwary surgeon. In this scenario, the motor branch actually pierces directly through the substance of the transverse carpal ligament itself.
Oh, wow. So it's literally inside the tissue you're trying to cut.
Exactly. If you blindly divide that ligament without meticulously clearing, visualizing, and protecting the undersurface and the distal edge, you will transect that motor branch. The result is the classic ape-hand deformity. It's a catastrophic and highly litigious outcome for the patient.
Okay, let's unpack this. If the carpal tunnel is essentially a crowded London Underground carriage, and the pressure within that carriage causes the electrical signaling delays in the nerve, why do we rely so heavily on clinical provocation tests that seemingly just agitate the nerve?
That's a great question.
I mean, I want to look closely at Phelan's, Tinnell's, and Durkin's tests. Previously, I might have thought of these tests as just shaking the train carriage, but mechanically, that analogy doesn't hold up, does it?
It doesn't hold up at all because we are not just agitating the nerve. We are fundamentally altering the pressure dynamics within the closed space. What's fascinating here is the physiological response of the interstitial fluid to these specific mechanical tests.
Talk me through the numbers. What are the baseline pressures?
In a normal, healthy carpal tunnel, the baseline resting interstitial fluid pressure is remarkably low, usually between 2 and 10 millimeters of mercury. The capillary perfusion pressure of the nerve is around 30 to 40 millimeters of mercury.
Okay, so at rest, blood flows freely into the intraneural microcirculation because the perfusion pressure is higher than the surrounding tissue pressure.
Precisely. However, the moment you ask a patient to perform Phelan's test, holding their wrists in unforced maximum palmar flexion for 60 seconds, you are not shaking the carriage. You are physically squeezing the walls of the carriage together.
You are mechanically collapsing the space and driving the pressure through the roof.
Exactly. During maximum flexion or extension, the intracarpal pressure in a compromised wrist skyrockets from that baseline of 10 up to 30, 60, or even 90 millimeters of mercury.
What?
Yes. And the moment the interstitial pressure exceeds the capillary perfusion pressure of 30 to 40, the venules collapse. Venous congestion occurs. The nerve is instantly starved of oxygen. You are inducing transient acute ischemia in a nerve that is already chronically compromised to see if it reproduces the patient's paresthesia.
Right. And Tinnell's sign, capping over the volar aspect of the wrist. Does that work the same way?
No, Tinnell's sign is testing for something entirely different. It tests the mechanosensitivity of irritated or actively regenerating axons. When a nerve is demyelinated or attempting to heal, the axonal membrane accumulates a high density of sodium channels at the site of injury.
Ah, I see.
So tapping physically triggers these hypersensitive channels, sending an ectopic action potential shooting down into the fingers. However, the literature consistently demonstrates that Durkin's test, the carpal compression test, is clinically superior to both Phelan's and Tinnell's.
Because with Durkin's, where the clinician applies direct, sustained manual pressure over the transverse carpal ligament with their thumbs for up to 30 seconds, you're bypassing positional changes and directly compressing the structures.
You are directly, artificially raising the intracarpal pressure to ischemic levels. It has the highest sensitivity and specificity because it most accurately replicates the exact pathological mechanism of compression without relying on the patient's joint mobility or tendon gliding.
Makes perfect sense.
However, while these provocation tests are vital tools in the clinic, none of them represent the ultimate diagnostic hallmark.
Which brings us to the clinical pearl that should make every single clinician immediately sit up and take notice. The undisputed hallmark of the condition.
Night symptoms. Nocturnal paresthesia and pain are the absolute non-negotiable hallmarks of carpal tunnel syndrome.
Right.
If the patient is not waking up in the early hours of the morning, hanging their arm out of bed, and vigorously shaking their hand to restore sensation, what we call the classic flick sign, you must urgently reconsider your diagnosis.
So if they only have pain while typing at their desk or only while lifting weights at the gym,
then you need to look proximally. Look for cervical radiculopathy at the C6 or C7 nerve roots. Look for pronator Carey syndrome in the proximal forearm. It is very rarely just primary carpal tunnel if they sleep perfectly soundly.
the physiology of sleep plays a massive role here, doesn't it? Why is the night so specifically cruel to the median nerve?
It is a perfect storm of fluid dynamics, temperature regulation, and posture. During the daytime, the active, repetitive movement of the fingers and wrist operates the skeletal muscle pump. This mechanical pumping action helps drain venous blood and lymphatic fluid proximally out of the hand and forearm.
Right, keeping the pressure relatively stable.
Exactly. But at night, that muscle pump is completely inactive. Furthermore, as we enter deep sleep, our core body temperature drops, and interstitial fluid naturally redistributes from the dependent lower extremities into the central and upper body.
So the entire upper limb becomes slightly more engorged with fluid.
Correct. Combine that fluid stasis and the interstitial volume expansion within the tenosynovium with the fact that humans naturally curl into a fetal position during sleep, unconsciously flexing their wrists.
So they're essentially doing a prolonged Phelan's test in their sleep while engorged with fluid.
Precisely. This sustained mechanical flexion, combined with the lack of a muscle pump and increased fluid volume, pushes the intracarpal pressure far above the perfusion threshold of the intraneural microcirculation for hours at a time. The nerve suffocates.
That sounds incredibly painful.
It is. Ischemic metabolites like lactic acid accumulate rapidly. The patient wakes up in agonizing pain, and the flick sign, the vigorous shaking, is an instinctual attempt to mechanically restore arterial perfusion and wash out those acidic metabolites.
When we connect this physiological reality to the landmark epidemiological evidence, specifically the population-based studies by Atroshi et al., it completely shifts our perspective.
It really does.
Atroshi's work demonstrated that while symptomatic carpal tunnel syndrome has a prevalence of around 3 to 4% in the general population, the prevalence of asymptomatic median nerve conduction abnormalities is staggeringly higher. We're talking about nearly 1 in 5 people having abnormal nerve signals, but 0 symptoms.
Atroshi's data is fundamental to modern practice. It proves unequivocally that the mere presence of abnormal neurophysiology, a slowed conduction velocity on a machine, does not equal a clinical syndrome that requires treatment.
Exactly.
Age-related changes, mild subclinical compression, or subtle anatomical variations can cause neurophysiological slowing. But the disease of carpal tunnel syndrome is defined strictly by the symptom burden. It is defined by the nocturnal ischemic pain, the daytime numbness, and the functional deficit. We treat the suffering, not the isolated mechanical slowing of a nerve impulse.
Which provides a robust, logic-driven segue into one of the most contentious areas in our practice. If the clinical signs, particularly the night waking and the flick sign, are paramount, why are we still so fiercely attached to electroddiagnostics?
The CTS-NCS discordance problem.
Exactly. We frequently encounter patients with classic, screamingly obvious clinical symptoms, yet the nerve conduction study comes back entirely normal. In a heavily litigious medical environment, an orthopedic surgeon or a GP without an abnormal NCS report might feel totally exposed.
Oh, absolutely.
If a patient claims a surgical release made them worse and you have no baseline abnormal NCS, you are arguably defenseless. So how do we justify skipping the scan?
This raises an important question regarding defensive medicine versus evidence-based clinical acumen. It is arguably the most common pitfall for trainees and mid-level clinicians. Nerve conduction studies, or NCS, are incredibly sophisticated investigations. They measure sensory nerve action potentials and compound muscle action potentials.
Right.
But their application is widely misunderstood. They are not, and should never be, a mandatory blanket screening tool for every patient with a classic clinical presentation.
So if the clinical signs are there, trust the clinical signs.
Yes. If you have a patient with nocturnal paresthesia in the median nerve distribution, a positive Durkin's test, and symptom relief with a neutral night splint, they have carpal tunnel syndrome. The guidelines support treating this patient based on clinical grounds alone.
But what about those early subtle cases where the discordance is highest? A patient has all the clinical signs, but the neurologist sends back a completely flat, normal NCS report. The trap here is assuming the machine is infallible and the patient is exaggerating.
And that is a dangerous trap. To navigate this, we must dive into the specific pathophysiology of early nerve compression and understand why the false negative trap exists. In the earliest stages of carpal tunnel syndrome, the pathology is purely vascular.
It's the ischemia we talked about.
Exactly. It is an intermittent, transient microvascular ischemia of the nerve driven by those nocturnal pressure spikes. Crucially, in this early phase, there is absolutely no structural damage to the myelin sheath or the underlying axon.
The myelin sheath, the insulating layer that allows for the rapid saltatory conduction of electrical impulses, is still perfectly intact.
Exactly. Because the myelin is fully intact at the nodes of Ranvier, the nerve conduction velocity, which is exactly what the NCS machine is primarily measuring, remains completely normal.
Because the electrical signal can still jump along a nerve at full speed when they're sitting in the clinic room.
Right. The large myelinated sensory fibers are conducting electrical impulses at optimal speeds when the patient is awake, comfortable, and the intracarpal pressure is normal in the neurophysiology laboratory.
So the machine is testing the nerve when it's not being suffocated.
Precisely. The actual demyelination, which physically slows the conduction velocity and prolongs the distal motor and sensory latencies on the report, only occurs much later in the disease process. It happens as a result of chronic, unrelenting edema, fibroblast proliferation, and eventual scarring of the epineurium.
So a negative NCS only tells you that the myelin hasn't suffered structural damage yet. It does not exclude the diagnosis of early ischemic carpal tunnel syndrome.
It absolutely does not. To deny a patient treatment because they have a normal NCS is to fundamentally misunderstand neurophysiology. You are effectively waiting for the nerve to sustain permanent structural demyelination just to satisfy an arbitrary diagnostic criterion.
But we must be balanced here. I mean, we cannot discard the NCS entirely. There are specific scenarios where electrodiagnostics are not just helpful, they are clinically mandatory.
Oh, without a doubt. They become mandatory when the presentation is atypical or confounded by systemic disease. If the patient's pain radiates proximal to the shoulder into the neck, you must order an NCS and an EMG to rule out a double crush syndrome or cervical root compression.
Right.
They are mandatory if there is objective, visible modal loss, such as profound lenar atrophy, to establish a definitive preoperative baseline for medical legal protection.
Because you need to prove the damage was already there before you operated.
Exactly. And they are highly recommended in special populations, such as severe diabetics or patients with underlying polyneuropathy, where the clinician needs to isolate the focal mechanical compressive element at the wrist from the systemic degradation of the peripheral nerves.
That makes perfect sense. So if early-stage patients often present with normal nerve conduction studies, we are left in a precarious position. We cannot easily justify taking a scalpel to a structurally normal nerve based on early ischemic pain alone.
No, you can't.
This forces us to rely on conservative bridging tactics. So moving into non-operative management, is it merely a delay tactic pacifying the patient, or is it a true therapeutic bridge?
It is highly dependent on the stage of the disease and the precision of the biomechanical intervention. The first line of defense, universally recognized by modern management pathways, is splinting and activity modification. But we must be meticulous about the biomechanics of the splint itself.
We aren't just blindly immobilizing the wrist in any rigid brace.
No. We are specifically prescribing a neutral resting splint for nocturnal use.
Let's clarify neutral, because a standard cock-up wrist splint, which holds the wrist in about 30 degrees of extension, is often handed out by default in A&E or primary care. But as you mentioned earlier, extension dramatically increases the intracarpal pressure.
It does. A 30-degree extension splint can actually exacerbate the ischemia. The volumetric capacity of the carpal tunnel is absolutely maximized, and the corresponding interstitial pressure is minimized when the wrist is positioned in strict neutral, or at most a mere 2 to 3 degrees of extension.
Right.
By forcing the wrist to remain in this neutral posture while the patient sleeps, we actively prevent the nocturnal mechanical pressure spikes. This allows the venous congestion within the perineural microcirculation to drain freely.
So for mild cases where the symptom burden is purely intermittent and nocturnal, a neutral night splint can be genuinely curative.
It physically breaks the compounding cycle of inflammation, venous engorgement, and ischemia.
But there is a tipping point, isn't there? When does a perfectly fitted neutral splint stop being a cure and start becoming a dangerous delay tactic?
The tipping point is the encroachment of daytime symptoms. If the patient reports that they are now experiencing numbness or tingling while driving their car, holding a telephone to their ear, or reading a broadsheet newspaper, it indicates that the baseline resting pressure in the tunnel has chronically elevated.
Even when the muscle pump is working.
Exactly. At this juncture, nocturnal splinting alone is entirely insufficient. Continuing to prescribe only splinting indefinitely for daytime symptoms is delaying definitive treatment while the nerve slowly, silently, undergoes focal demyelination.
This is exactly where the corticosteroid injection is deployed in the pathway. But here's where it gets really interesting. If we examine the pharmacological data, a steroid injection typically only provides 3 to 6 months of symptom relief in moderate carpal tunnel syndrome.
That's accurate.
So aren't we just kicking the proverbial can down the road? At what point is conservative management actually doing a disservice to the nerve's long-term microstructural health?
That is the central tension in conservative management. We have to understand the mechanism of action. Corticosteroids, like triamcinolone or methylprednisolone, are exceptionally potent anti-inflammatory agents. They work by downregulating inflammatory cytokines, such as TNF-alpha and interleukin-1, within the carpal tunnel.
Which stops the swelling.
It rapidly reduces the vascular permeability and subsequent swelling of the tenos synovium, the massive volume of tissue surrounding those 9 flexor tendons. By chemically shrinking this tissue, you immediately artificially increase the available spatial volume for the median nerve.
So the pressure drops, the ischemia resolves, and the symptoms vanish.
But, as you astutely pointed out, the pharmacological effect is finite. The drug metabolizes, and the effect typically wanes after 3 to 6 months. We are not curing the fundamental anatomical discrepancy of the tight ligament. We are just temporarily modifying the inflammatory microenvironment.
So how should a mid-senior clinician appropriately position the injection within their treatment algorithm without just stringing the patient along?
We must completely reframe the purpose of the steroid injection. It is not just a treatment, it is a vital diagnostic and therapeutic bridge. If a patient presents with moderate symptoms, an injection provides immediate, profound symptomatic relief, allowing them to sleep peacefully, return to heavy work, and function normally.
That's the therapeutic bridge. It buys the patient highly functional time.
But far more importantly, it acts as an unparalleled diagnostic tool. If the injection completely abolishes the neurological symptoms for 3 months, you have unequivocally chemically proven that the median nerve compressed within the carpal tunnel is the sole anatomical pain generator.
It's essentially a low-risk pharmacological confirmation of the diagnosis.
Precisely. When the symptoms inevitably return as the steroid wears off, you can confidently list that patient for a surgical release, knowing with near absolute certainty that the structural decompression will be successful. Conversely, the flip side is critical. If a properly administered steroid injection provides absolutely zero relief, you must immediately pause. You must fiercely question your working diagnosis before ever considering taking that patient to the operating theater. A failed injection often points towards cervical radiculopathy or peripheral neuropathy.
And speaking of properly administered, the technique is rapidly evolving, isn't it? We are moving away from blind anatomical landmark-based injections. The modern standard is leaning heavily toward ultrasound guidance.
It is, and for excellent biomechanical and safety reasons. Experienced hand surgeons certainly have acceptable success rates using traditional anatomical landmarks, typically injecting just ulnar to the palmaris longus tendon to purposefully avoid the median nerve trajectory.
But there's always a risk.
Always. However, high-frequency ultrasound using a 15 to 18 megahertz linear probe elevates the precision from acceptable to absolute. It allows the clinician to directly visualize the median nerve in real time, measure its cross-sectional area, where anything over 10 millimeters squared at the level of the pisiform is highly diagnostic of compression, and safely guide the needle.
You can watch the injectate flow precisely into the perineural space,
Yeah.
hydrodissecting the nerve away from the surrounding flexor tendons.
Crucially, ultrasound completely eliminates the risk of an accidental intraneural injection. Accidentally injecting a crystalline corticosteroid directly into the substance of the median nerve is a devastating, heavily litigated complication that can cause permanent, irreversible axonal necrosis. Ultrasound prevents this entirely.
Amazing. So we have utilized our neutral splints. We've successfully deployed our targeted steroid injections as a diagnostic and therapeutic bridge, but the biological clock has run out and the symptoms have returned.
Right.
The pathways are explicit at this stage. Conservative measures have exhausted their utility, and mechanical surgery is the definitive step. But as we step into the operating theater in 2026, the debate over exactly how to release that nerve is still fiercely contested. Welcome to the surgical evidence wars.
It's a debate that has raged at conferences for decades. We must remember that the fundamental mechanical goal of the surgery is identical regardless of the chosen approach. We need the complete, uncompromising division of the transverse carpal ligament to definitively increase the volumetric capacity of the carpal tunnel.
But the modalities, the traditional open release, the mini-open, and the endoscopic techniques, They represent vastly different philosophies regarding surgical trauma and collateral tissue
Oh,
damage.
yes, they do.
Choosing a surgical approach here has often been compared to fixing a car engine. The old analogy suggests that you either open the bonnet completely for full visibility, sure you don't miss a single detail, or you use a keyhole camera to avoid scratching the paintwork.
I've heard that one.
But I think that metaphor severely minimizes the anatomical reality. We aren't just trying to avoid scratching the paint. An open release involves slicing directly through the palmar aponeurosis, which is a major load-bearing, highly innervated structure of the hand. The collateral trauma is significant.
If we connect this to the bigger picture, your critique of the metaphor is spot on. The traditional open release involves a longitudinal incision directly within the palm, fully dividing the skin, the subcutaneous fat, and the dense palmar fascia, just to expose the entire length of the ligament.
And what's the real advantage of doing all that?
The absolute advantage of this approach is uncompromised, direct macroscopic vision. You can clearly see the median nerve, you can instantly identify those treacherous recurrent motor branch variations like the transligamentous course we discussed earlier, and you can visually, undeniably confirm the complete division of the extreme distal margin of the ligament.
But the biological cost of that uncompromised vision is the prolonged recovery.
The cost is indeed high. Because you are dividing the highly innervated palmar fascia and disrupting the mechanical architecture of the palm, patients face a longer recovery time, a delayed return to heavy manual labor, and the notorious complication known as pillar pain.
Ah, pillar pain.
Yes, pillar pain is a deep, frustrating aching in the thenar and hypothenar eminences that can persist for weeks or even months as the transverse carpal arch slowly remodels and the soft tissue scar.
Which is exactly why the endoscopic approach was championed so aggressively. The philosophy is to minimize the soft tissue trauma, preserve the palmar aponeurosis, and accelerate recovery. But when we strip away the surgical bravado, what does the landmark evidence actually dictate?
We have to look at the data.
Let's look closely at the Schulten-Cochran review and the pivotal Gerritsen trial comparing open versus endoscopic release. Where does the true consensus lie?
The evidence is incredibly revealing and often humbles staunch advocates on both sides. First, the Schulten-Cochran review definitively established the baseline. Surgical release of any kind is vastly superior to prolonged splinting for long-term symptom resolution.
So surgery works?
Surgery works. But when we drill deeply into the Gerritsen trial and the subsequent rigorous meta-analyses comparing the open technique to the endoscopic technique, a striking reality emerges. If you look at the long-term outcomes specifically at 6 months and 1 year postoperatively, the results are virtually identical.
Really?
Identical.
Yes. The recovery of grip strength, the complete resolution of neurological symptoms, and overall patient satisfaction entirely converge.
So the final destination is exactly the same, but the initial journey for the patient is different.
The journey is the differentiator. The endoscopic approach, whether utilizing the single-portal AG technique through a small transverse wrist crease incision, or the Chow two-portal technique, allows the surgeon to divide the transverse carpal ligament from the inside out.
The blade is deployed upward, cutting the ligament while leaving the overlying palmar fascia and skin completely undisturbed. The data unequivocally confirms this leads to significantly less immediate postoperative pillar pain and a measurably faster return to work, usually by an average of 1 to 2 weeks compared to the open surgery cohort.
But there is a massive looming caveat there, isn't there? The learning curve, the visual limitations, and the specific complication profile of the endoscopic approach.
That is the crux of the ongoing controversy. Endoscopic release has a notoriously steep and unforgiving learning curve. The surgeon is relying on a two-dimensional screen, working within a highly confined, potentially obscured space.
And if things get messy?
Exactly. If the camera lens fogs or a minor venous bleed obscures the field, spatial awareness is compromised. Consequently, the statistical risk of transient neuropraxia, temporary damage to the median or ulnar nerve due to scope manipulation, is marginally higher in the endoscopic group, particularly in the hands of surgeons who have not surpassed the learning curve volume.
That makes sense.
Furthermore, the risk of an incomplete release of the ligament is a very real concern if the distal margin is not perfectly visualized on the monitor. Therefore, the choice of modality in 2026 is less about one technique being universally superior and much more about matching the individual surgeon's specific expertise and operative volume with the patient's anatomical complexity and occupational demands.
Which seamlessly brings us to the darkest, most challenging corner of our deep dive. Despite the robust evidence, Despite the advanced endoscopic technology and the refined mini-open techniques, patients still return to the clinic.
They do.
They sit across from you, clutching their hand, reporting that the exact same pain, or even worsened pain, has persisted months after the operation. Let us dissect the anatomy of a failure. When things go wrong, what is the biomechanical culprit?
It is a profoundly frustrating scenario for both the patient who feels betrayed by the surgery and the surgeon. When evaluating a patient with a failed carpal tunnel release, the clinician must meticulously separate the timeline into persistent symptoms, recurrent symptoms, and entirely new symptoms. But statistically, examining the revision literature, I can state unequivocally that the single most common cause of a failed carpal tunnel release, accounting for the vast majority of early surgical failures, is an incomplete release of the transverse carpal ligament.
Why does this happen so frequently? What is the specific anatomical trap that consistently catches competent surgeons out?
The trap lies at the extreme distal end of the ligament near the exit of the tunnel. As the distal transverse carpal ligament extends into the palm, it merges imperceptibly with the fascia of the hypothenar and the thenar muscles.
It sort of blends in.
Exactly. More critically, this distal edge is intimately related to the superficial palmar arch, the primary arterial blood supply to the digits, formed mostly by the ulnar artery. Cautious or inexperienced surgeons, acutely fearful of causing a catastrophic arterial bleed or blindly damaging a recurrent motor branch in the fat pad, will prematurely halt their distal dissection.
So they stop cutting too soon.
Yes. They successfully divide the proximal and middle portions of the ligament, but leave the final few millimeters of the distal fibrous edge completely intact.
And those few uncut millimeters act like a tight band, maintaining an hourglass constriction on the nerve.
A partially cut ligament is an uncut ligament as far as the median nerve is concerned. The nerve remains mechanically crushed at the distal exit. Another common anatomical trap, particularly in mini-open procedures, is confusing the superficial palmar aponeurosis for the deeper transverse carpal ligament.
Wait, they cut the wrong layer.
They cut the superficial fascial layer, see the underlying fat pad bulge upward, and falsely assume they have completely decompressed the tunnel. Meanwhile, the true, thick, restrictive transverse carpal ligament lies deeper, entirely untouched by the scalpel.
So what does this all mean for the surgeon mid-operation? How do we definitively physically prove to ourselves, while the patient is still on the table, that the distal transverse carpal ligament is fully released without causing iatrogenic injury?
You cannot rely solely on a visual assumption. You must rely on tactile physical confirmation. Once you believe the release is complete, you must be able to comfortably pass a blunt instrument such as a McDonald dissector or the closed, blunt tips of a tenotomy scissor distally beneath the palmar skin, but remaining superficial to the median nerve.
Okay, feeling for resistance.
The instrument should glide smoothly into the soft, unresisting fat of the mid-palm without catching. If you feel a tight, rigid, fibrous band catching the tip of the instrument, the release is incomplete and you must extend your incision. Furthermore, you should visually inspect the epineurium of the median nerve itself.
You are looking for the hyperemic blush.
Yes, the hyperemic blush is a beautiful physiological response to mechanical decompression. For months or years, the intraneural capillaries have been mechanically crushed. The moment you fully divide that stricture, the sudden release of pressure allows reactive hyperemia. The capillaries rapidly dilate to wash out the accumulated metabolic waste, and the pale, flattened nerve adopts a sudden, vivid return of pink vascularity. If you do not see that hyperemic blush, you must question if a distal fascial band is still compressing the nerve.
That is a phenomenal intraoperative framework, but let's bring it back to the outpatient clinic. A patient presents at 6 weeks post-op with moderate to severe palmar pain. How do we differentiate normal, expected post-operative pillar pain from a failed, incomplete release that urgently requires revision surgery?
This requires careful, targeted, clinical detective work. Normal postoperative pillar pain is typically mechanical in nature. It is a deep, aching pain located specifically in the fleshy, muscular parts of the palm, the thenar and hypothenar eminences.
Which we discussed earlier.
Yes. Crucially, this pain worsens with direct mechanical pressure, like pushing up from a chair or gripping heavy objects as the carpal artery models. However, despite this aching, the patient will almost universally report that their original classic nocturnal waking and the sharp shooting electrical pingling have completely resolved.
So the median nerve is happy and decompressed, but the surrounding soft tissues and recovering fascial planes are complaining.
Exactly. The nerve is free, but the architecture of the hand is adapting. Conversely, a massive red flag for a failed incomplete release is a patient who sits down and states, "Doctor, the exact same tingling, the exact same numbness, and the night waking are still there."
Oh, wow.
If the specific neurological symptoms have not changed one iota since the day of the operation, you must highly suspect an incomplete distal release.
And how do we definitively investigate that suspicion before opening them back up?
High-resolution ultrasound is now our primary investigative modality for this scenario. An experienced ultrasonographer can dynamically assess the continuity of the ligament postoperatively. They can clearly visualize if the median nerve remains tethered, flattened, or compressed beneath an uncut distal fascial band.
And if they find it.
If an incomplete release is structurally confirmed, revision surgery is strictly indicated. However, the patient must be counseled that revision is significantly more complex. It must be performed as an extended open procedure, and it often requires microscopic neurolysis meticulously dissecting and freeing the nerve from the dense, restrictive, post-operative scar bed that has formed since the first surgery.
The anatomical complexity is staggering. And what is vital to remember is that we have only been discussing the standard, otherwise healthy patient. But standard management pathways only work for standard physiology.
That's a crucial point.
The clinical reality is that severe systemic physiological stressors completely alter the carpal tunnel's microenvironment. Let us move into our final section, special populations. We need to talk about triage, tailored care, and why standard algorithms will outright fail these high-risk cohorts. Let's start with a very common presentation, pregnancy.
Right. Pregnancy fundamentally alters both the biological timeline and the standard rules of engagement. Carpal tunnel syndrome in pregnancy is incredibly common, typically presenting acutely in the third trimester.
But it's a different mechanism, isn't it?
It is not driven by repetitive strain or chronic ligamentous thickening. Instead, it is driven by systemic hormonal fluctuations, massive total body fluid retention, and the systemic effects of the hormone relaxin on the connective tissues. The limited space of the carpal tunnel literally fills to capacity with engorged interstitial fluid.
But the crucial defining difference here is the long-term prognosis.
Precisely. Unlike idiopathic carpal tunnel syndrome in the general population, which is generally a progressive worsening mechanical condition, pregnancy-induced CTS is self-limiting in the vast majority of cases.
Once the baby is delivered.
Following delivery and the subsequent massive postpartum diuresis, the systemic fluid shifts rapidly reverse. The interstitial volume drops, the intercarpal pressure normalizes, and the neurological symptoms resolve spontaneously.
So how do we treat them in the meantime?
Therefore, conservative management is heavily, almost exclusively favored. We rely on strict adherence to neutral night splinting and patient reassurance. We reserve targeted steroid injections only for extreme, intractable pain that prevents sleep entirely.
And surgery.
Surgical release is almost never indicated unless there is profound, irreversible motor loss, such as severe thenar atrophy, which is exceedingly rare in this specific cohort.
What about diabetes mellitus? This is an entirely different beast. A massive portion of our patients are diabetic. How does the presence of systemic diabetes change our threshold for surgery and alter the nerve's resilience?
Diabetes complicates the clinical picture exponentially due to the biochemical phenomenon of double crush and the highly toxic underlying metabolic environment. A diabetic patient very often has an underlying peripheral sensory neuropathy. Their nerves are already metabolically sick and compromised before they ever enter the carpal tunnel.
Let's explore why they are sick. This comes down to the sorbitol pathway and advanced glycation end products, doesn't it?
Yes. In chronic hyperglycemia, excess glucose is metabolized into sorbitol by the enzyme aldose reductase. Sorbitol does not readily diffuse out of the nerve cell membranes, leading to an osmotic gradient that draws water into the Schwann cells, causing pathological swelling and structural damage to the myelin.
So the nerve is physically swelling from the inside.
Exactly.
Yeah.
Furthermore, advanced glycation end products, or AGGs, accumulate and stiffen the connective tissues of the epineurium.
So the nerve is biochemically swollen, the surrounding connective tissue is stiffened, and the axoplasmic transport of nutrients from the cell body is failing. The nerve is incredibly fragile.
That is the essence of the double crush concept. When a metabolically fragile, swollen nerve is subjected to even mild mechanical compression at the wrist, it fails much faster and suffers irreversible damage much earlier than a healthy nerve would.
So we have to adapt.
Therefore, our threshold for intervention must adapt significantly. While we still utilize conservative measures like splinting, we monitor these patients much closer. We rely heavily on nerve conduction studies in diabetics to differentiate the focal mechanical compression at the wrist from the systemic stocking glove peripheral neuropathy.
And the consent process for surgery must be entirely different.
It must be brutally honest. We must explicitly counsel the diabetic patient that while a surgical release will successfully relieve the focal mechanical pressure at the wrist, it absolutely cannot cure their underlying diabetic neuropathy.
Right.
Their ultimate symptom relief post-surgery may be markedly less profound than a non-diabetic patient, and the biological recovery of their nerve function is often slower and frequently incomplete.
That manages patient expectations beautifully and protects the surgeon from claims of a failed surgery when the remaining symptoms are purely metabolic. Finally, we must touch upon the structural changes, the systemic conditions that physically alter the anatomy of the wrist. I'm talking about the inflammatory arthropathies, like severe rheumatoid arthritis, and patients on long-term hemodialysis. How do they fit into the 2026 surgical landscape?
These specific patients require the orthopedic surgeon to act far more like a medical detective, heavily integrating rheumatological and renal data into the preoperative surgical plan. In rheumatoid arthritis, the primary compressive pathology is almost never a simple thickening of the transverse carpal ligament.
What's driving it then?
The culprit is a massive, aggressive, proliferative tenosynovitis of the flexor tendons. The synovial tissue surrounding those 9 tendons becomes deeply hypertrophic. It forms an invasive pannus that physically crushes the median nerve against the roof of the tunnel.
Which means a standard, quick endoscopic release of the ligament is going to fail entirely.
A simple ligament release is entirely insufficient. These patients frequently require a comprehensive open procedure. You must fully open the tunnel and perform a meticulous, extensive flexor tenosynovectomy, physically excising and clearing the diseased, hypertrophic synovial tissue from every single tendon to truly decompress the canal.
Wow. And the dialysis patients, they have a fascinating, though devastating, pathophysiology.
Patients on long-term hemodialysis develop a highly unique structural pathology known as beta-2 microglobulin amyloidosis. Beta-2 microglobulin is a specific protein with a molecular weight that prevents it from being effectively cleared by standard dialysis membranes.
So it builds up.
Because it cannot be filtered out of the blood, it circulates and eventually precipitates, depositing directly into the osteoarticular tissues, specifically the transverse carpal ligament and the flexor tenosynovium.
It essentially turns the soft, pliable tissues of the wrist into rigid, restrictive blocks of amyloid.
It fundamentally alters the structural anatomy. Standard diagnostic algorithms and conservative treatments fail here because the mechanical compression is relentless and progressive due to ongoing amyloid deposition. Surgery is almost always required to physically decompress the nerve.
But the underlying condition is still there.
Exactly. However, the surgeon must warn the patient that the recurrence rates are significantly higher in this cohort, simply because the systemic deposition of the beta-2 microglobulin protein continues unabated even after the ligament is divided.
It is a profound, sobering reminder that as orthopedic surgeons, we are not just carpenters fixing a local mechanical problem. We are operating within a deeply complex, highly interconnected systemic environment. The health of the whole patient dictates the survival of the nerve. We have covered an immense, rigorous amount of ground today. Let's synthesize the absolute core clinical pearls to truly cement the listener's learning before we close. First, night symptoms are the ultimate non-negotiable hallmark. If the paresthesia and pain aren't waking the patient and causing the flick sign, you must urgently reconsider the diagnosis. Look to the cervical spine or the proximal forearm.
Right. To build on that, the second pearl. A normal nerve conduction study absolutely does not rule out early ischemic carpal tunnel syndrome. You must treat the patient's severe clinical symptoms, not just the intact neurophysiology report.
Third, corticosteroid injections offer an excellent 3 to 6 months of symptom relief, but more importantly, they should be viewed as a brilliant diagnostic bridge. They definitively confirm the anatomical pain generator before you ever commit to the scalpel.
Spot on. And finally, if a patient returns with unrelenting, unchanged symptoms after surgery, a failed carpal tunnel release is almost always due to an incomplete mechanical release of the extreme distal transverse carpal ligament. Meticulous intraoperative tactile confirmation with a blunt instrument is non-negotiable.
Incredible, practice-changing insights. If today's clinical deep dive sharpened your practice and challenged your assumptions, please take a moment to rate the show and share it with your colleagues and trainees.
As a wrap-up, I want to leave you with a provocative thought regarding the future trajectory of our field. We have spent the last century mastering the mechanical release of the nerve, refining our open and endoscopic tools. But as we witness the rising global tide of systemic metabolic conditions like diabetes and inflammatory arthropathies, we must ask ourselves a critical question. In the next decade, will carpal tunnel syndrome continue to be treated primarily by the mechanical scalpel, or will the future lie in pharmacologically addressing the hostile cellular microenvironment of the nerve itself?
A brilliant question to leave hanging in the air for our listeners to mull over. Remember, we started today by looking at that glaring clinical paradox. The most common compressive neuropathy still resulting in massive diagnostic delays and devastatingly failed surgeries. Perhaps the definitive key to solving that paradox isn't just learning how to cut the ligament more precisely, but finally understanding exactly what is happening in the murky metabolic waters beneath it. Thank you for joining us on this deep dive. Stay curious, trust your clinical exams over the machines, and we will see you next time.